Hi, everyone, and welcome to our ECMO breakout session. I'm Julie Montaguto. I am the ECMO director at Hasbro Children's Hospital at Brown University and the vice chair of the Critical Care Committee. And I'll be moderating this session with our panelists.
Hi, everyone. I'm Patrick McGovern at Phoenix Children's Hospital, also one of the surgical critical care faculty members there.
Keith Thatch, John Hopkins All Children's, pediatric trauma and surgical director over at Tampa General, as well as part of the CDH unit at All Children's.
Hi, I'm Allie Linden. I'm a pediatric surgeon at Emory University Children's Healthcare of Atlanta. I am our ECMO surgical director, as well as the program director for ECMO Fellowship.
So we have no disclosures, although we have some slides that have been borrowed from dear friends and colleagues. And we're going to be talking about a number of high-impact topics today in our short time. And these are going to include some ECMO controversies, doing procedures on ECMO, and then emergencies and what to do when you get into trouble. So to start out, we're going to talk about some generally accepted cannulation criteria, although these can vary from center to center. So common criteria to consider for ECMO candidacy are that we have a reversible cause of cardiorespiratory failure or a reasonable exit strategy, gestational age greater than 34 weeks, greater than 2 kilograms, or less than or equal to grade 2 IVH, and no contraindications such as an active bleed. And we are even now starting to push some of those limits in some centers and in certain cases. So in some situations, we may be talking about preterm infants greater than 30 weeks or a birth weight that is more than 1.5 kilos. Still always considering being able to place the cannulas and the size of the vessels, that can be a limitation. And in some situations, considering a grade 2 bleed or less with close surveillance. So with that, we'll go on to, we're going to try to make this case-based, and please feel free to ask questions as we go along. But our first case, which is a 12-year-old female with ALL. She is on delayed intensification chemotherapy with an absolute neutrophil count of 25. She develops respiratory failure and septic shock. And we speak with the oncology team, and they tell us that this is treatable. So now we'd like to ask the audience, just by show of hands, how many people would consider cannulating this patient? Would she be considered an ECMO candidate? Great.
So about half, it looks like.
Patrick, can you tell us how you would approach this patient?
Sure, thank you. So it looks like about half of you said that you would be willing to cannulate this patient. You know, when I first started training way back when, before I even knew anything about ECMO really, one of the teachings was that, or at least one of the things that was always said was like, well, this patient has cancer, so we really shouldn't be offering them ECMO or something that's as resource intensive with a high likelihood of failing. And, you know, that certainly, that sort of stuck with me all the way throughout my training. And so I thought it would be helpful for this session to look at, well, what have the numbers been over the past decade and even 2 decades, really? And it certainly seems like, you know, there's a wide number of studies which unfortunately don't have a great degree of granularity, but this is a meta-analysis of a bunch of them that were done up to 2020. And the actual ECMO mortality varies pretty widely amongst these studies. Some studies report, you know, a mortality as high as 75%. Some of them report relatively equivalent survivals to, you know, the pediatric numbers for the non-oncologic population. And it sort of goes across the board. Some of the studies also looked at whether or not there's the same rates of, you know, morbidity and complications. And again, it's a little bit difficult to suss out, mostly because of the granularity of the database that we're using. But again, you know, things have been changing over the past 10 or 20 years or so. And so one of the other things that you have to worry about with ECMO, of course, is that, you know, patients who have been treated for oncologic reasons and maybe have bone marrow failure also, unsurprisingly, aren't able to generate their platelets. They have a lot of clotting abnormalities. And one of the things that I always heard coming up was that, well, they're also coagulopathic, right? Because they don't have the same levels of factors. They don't have the same level of cells that they need. And this is just a single center study, but it's pretty, you know, representative and demonstrates how a lot of these patients do end up requiring more product when they're cannulated and on circuit. there's some papers, especially early on, that say, that the bleeding risks are higher. But in some of the more recent papers, it does seem that requirement for a product on circuit is true, and that it does seem like they do require more platelet transfusions, more FFP, and even more RBCs. But at least for this propensity match study from about 9 centers or so, it seems that the product numbers are higher, but the bleeding scores are relatively equivalent. Or in other words, it doesn't seem like they bleed any more than your regular pediatric ECMO patients. In addition, this is one of the studies that showed that the survival to hospital discharge was equivalent between the two groups. Now, not every study shows that, and there's, again, like I said, still a lot of variability, but it seems that there are more studies coming out that say that these patients can survive their cancers, they can survive their cannulation, and the numbers are getting closer to the regular pediatric population. When you look at HSCT or hematopoietic stem cell transplantation, again, another sort of like third rail, these kids are very, very sick. They have absolutely no bone marrow left, and they're susceptible to a lot of infections. Certainly, back in the 90s and early 2000s, the numbers for survival were pretty abysmal. But even those numbers now, with the advanced therapies and PICU and support that we have, the numbers are improving, and patients are making it out to a guesstimated number of about maybe 20% of patients now with the recent hematopoietic stem cell transplantation can get through their ECMO cannulation and can make it to hospital discharge. And so all of this has sort of resulted in a multidisciplinary consensus statement that was released in The Lancet around 2022, which essentially says, and it's obviously a pretty big graph, it essentially says that you should at least be having a multidisciplinary discussion with all the providers involved. And unless there's a clear indication that this patient's not going to survive either their cancer or for other reasons like profound systemic illness and instability, you really should at least be thinking about offering ECMO. And there is some value, particularly if your institution has the resources and it wouldn't take away from any other patient's care. You should be thinking about ECMO for these patients. And so that's one of the things that we've done at Phoenix Children's, where we do have a multidisciplinary discussion where, again, unless the cancer is not survivable for just the nature of disease, or unless it's very obvious that the patient's probably not going to survive for other reasons, we talk about it, and we do offer them ECMO in these situations. So this is just sort of a summary slide. In the interest of time, I'll just have you guys look at this real quick, and I think we'll move on to the next case.
So our next case is a 3-week-old ex-full-term male. Oh, there's a question. Yeah.
I don't know. Yeah. Do you guys have those conversations as soon as the patients are admitted to the PICU or whatever's elevating their care? I found in fellowship it was really, really hard to get everybody to agree on if they're a candidate for ECMO once they already needed it. And we had a hard time getting buy-in and sort of as soon as they're admitted to the PICU, even if they're not there yet, should we decide on their candidacy? Do you guys have a good system for that or any recommendations?
No, that's an excellent point. Actually, as part of the consensus statement or the summary recommendations, they actually say that you need to think about ECMO and you need to offer it and cannulate as early as possible, because the survival seems to be improved the earlier you cannulate, particularly with regard to HSCT patients. And so, we make a good effort. Anytime there's any kid that they may think, particularly if, they're getting CAR T therapy or there's a chance that they may get sick, we do try to have that discussion. And the PICU has certainly been very good about reaching out to us, but we still do have those occasions where it's a little bit unexpected and you're still having, a conversation. Well, does this patient even qualify for ECMO? Which is part of what, the Phoenix Children's guidelines that we had there were developed in response to, but we always could be better,
So our next case is a 3-week-old ex-full-term male with respiratory failure of unknown etiology who's on VV ECMO. And at this point, the question has come up about doing a lung biopsy, and the family wants to have everything done. So Keith, would you tell us your approach to performing procedures on ECMO?
Yeah, so I think the biggest thing here, and I think even to the point before, is having that really kind of the concentration of where the ECMO guidelines and a lot of this is having some sort of institutional guideline, having a multidisciplinary so forth. When we're looking at doing procedures on ECMO, it's really kind of figuring out what the decision threshold is. And so if you look at the Red Book, there's really 3 questions that we're kind of looking at. And it's not necessarily, can we do the procedure? Is it needed? It's, can we avoid the procedure, actually? Is there a way for us, can we get through this without the procedure? When does it need to be done? So first, do we really need to do it? So is that lung biopsy going to change the course? Well, maybe we're not getting off ECMO unless we know the pathophysiology so that we can potentially treat and get off ECMO. So yes, it will. And then the next part is, when is the best time to perform it? Is this something that we can plan with that team? Can we get it in the best optimal setting in the operating room with our services and so forth and go from there? And then, to be honest, the third question is, am I the right person to do this? Is there a specialty team at your kind of institution where that team is really responsible for doing procedures on ECMO and really focused and really kind of specialized? And so going through those first parts of the decision threshold will lead you kind of to those procedures, or whether you need to or not. If you look at patients that have had some sort of surgical procedure then land onto ECMO, and about a third of those will have bleeding complications when they get in the ECMO. 30% will potentially need to go to the operating room, and 20%, even 20% of neck cut downs may need some sort of re-intervention. When we look at our post-trauma patients, we also see that kind of same couple days later where they may have some bleeding. In the adult population, you see that in the 20%. The University of Utah group has shown up to 17% in the pediatric population potentially needs a hemorrhage control or potential surgical. There are patients that we put on ECMO where we know that they potentially have that we're putting them on to treat something that we know that needs to be treated potentially on ECMO. And so are these underlying disease processes that necessitate the ECMO support in the beginning? These are our CDHs, our congenital lung lesions, the patients that need sepsis control, or that pulmonary failure we don't know that potentially may need that lung biopsy. There are also procedures that end up more as complications from those interventions. And so these are the chest tubes. Up to 10% of pediatric patients will need a chest tube placed during their ECMO run, as well as up to about 5% can even need a tracheostomy. So when we look at that, why is that happening on our pre-patients, on our patients that are having some sort of either trauma or pre-surgery? We see that the consequences afterwards of cannulating is we start to see the clots that initially had been kind of holding us stable, they start to lyse. We start to see that the fibrin becomes depleted. And with all that, we start to see bleeding that begins again around day 2 to day 5 in some of these patients. So this has led to some of the pediatric ECMO anticoagulation collaborative has come together, and they've created a consensus. And this is kind of looking at 4 different populations, looking at low bleeding risks, high bleeding risk in our post-cardiac surgery, and then our high bleeding risk in our non-cardiac surgery patients, and then kind of just overall thinking about the peri-procedural bleeding risk. And a lot of these surmise, the ideals behind all this will surmise into kind of the same kind of principles of how we kind of attack a peri-procedural bleeding risks. And we'll do that through a kind of a case study. And I'd like to bring it back to the father of ECMO and Dr. Bartlett, and kind of bring back to one of his bedside chats in the ECMO ELSO newsletter in December 2016. He brought a case of a 16-year-old, 80-kilo boy who was placed on VV ECMO for respiratory failure support 2 days after following trauma. He had major trauma, multiple rib fractures, tension pneumothorax, pulmonary contusions, got a chest tube, pulmonary contusions flared into ARDS, placed on ECMO. But then on his 3rd day after ECMO, he begins to bleed from the chest tube in the right. And his bleeding is at 500 cc's an hour. What's happening? We just talk about the depletion of all of our clots, the fibrinolysis, all the things that are happening. What can we do? How do we manage this situation? So first, can we avoid, we go right back to that decision threshold. Can we avoid it? When's the best time to do it? Am I the right person? So what's the best next step? Who wants to place a second chest tube? Anyone? Who thinks we should stop the heparin, replace platelets and factors? Who thinks we should do an emergency bedside thoracotomy at 500 cc's an hour right now? All right. Who thinks we should transfer to the OR for a thoracoscopy, excuse me? And we should continue support, replace product, and keep up with the blood loss? All right. Well, yes. So the first stop of this is maybe decreasing our anticoagulation. So can we avoid the OR? let's see if we can avoid it. Can we actually come back down? Can we come off our heparin? Can we come off our bivalve? Can we half it? Can we keep our transfusions threshold up as much as we can? And can we get that controlled? We want to stop that anticoagulation according to the PEACE recommendations. We want to keep our platelets above 100,000. We can keep our fibrinogen above 150, FFP, factor replacement. We also want to start adding our lysine analogs with our Amicar, maybe our TXA. We want to start at a loading dose and potentially run these for about 24 hours, these dose. The one that is tough is the factor 7. If you look at the factor 7 data, really should only be used for life-threatening or refractory bleeding. This has really shown a lot of kind of thrombotic complications and can lead to worse outcomes for these patients unless we are life-threatening. So we stopped this, but despite this, our change in anticoagulation guideline adjunct usage, we're still bleeding at about 300 cc's an hour. It's about 24 hours later, we've been replacing blood. When do we operate? So do we do this after we take them off ECMO? Well, yes, that's ideal, but it doesn't look like we're getting off ECMO. After the blood bank calls and said all the blood's gone, missed our window. What about after 6 units? What's special about 6 units? Well, at 80 kilos, if we look at this, blood volume somewhere in about 5.5 range, probably about half of his blood volume, or 6 units is about the time frame where we want to think about kind of going. So if we look at these guidelines and we look at kind of what ELSO defines as major bleeding, it's kind of leading us to these pathways. And if you talk to Dr. Bartlett and kind of my former colleagues at Michigan, we're talking about half that blood volume, just like we talked about. But looking at these as reasons why and when to go to the OR. But what procedure do we do? Anybody want to go to IR? Thoracoscopy? This one, at least, it's a thoracoscopy. Thoracotomy or damage control thoracotomy. Well, what's the difference? Well, really, any of these situations, we're going damage control. We're getting in there. We're trying to tamponade this bleeding as best we can. We don't want to cause any more bleeding. And we want to use our simple kind of damage control principles. We're not using blades. We're going in with electrocautery. Maybe we're doing that for our chest tubes and everything else like that. We're clearing clot, lighting vessels. We're resecting bowel if we're in the belly. We're not doing anything definitive. And then we also want to use topical hemostatic agents. These can have shown to be beneficial, and this is part of the PEACE recommendations. And then at the end, we're going to leave these spaces open, or we're going to leave a large drain, and we want to watch this close. So if we look at that PEACE consensus recommendations and the high bleeding risk procedures, we want to use, as we was talking about before, it's really important to have that institutional guideline on management of systemic anticoagulation and transfusion therapy. We want to decrease or stop systemic anticoagulation when we have these major bleeding events. We want to consider the lysine analog antifibrinolytics. We want to reserve that factor 7 for that life-threatening bleed. We want to use the prophylactic application of our topical agents, and we want to maintain our transfusion thresholds. These are the main things that really affect any sort of bleeding that we see there, and you can modify that based on the level of bleeding as you kind of go. But having that team together working on it and having that consensus at your institution is paramount. As we look at that, we want to really kind of have that multidisciplinary conversation. Do we really need the procedure? Less is more. But sometimes more is better. So really kind of thinking through everything, trying to make sure that we really are doing damage control, making sure that we know our hemostatic paradigms, make sure that our transfusion thresholds are there, we trust all of our colleagues, and that we use that multidisciplinary discussion and plan procedure as we go. So really kind of having a thought process through this and thinking about it before you're putting on ECMO or when you're on ECMO, always having that thought in place to what if we bleed? What are we going to do? When are we ready? What are our thresholds to intervene?
So just advance the slide there. So our next case brings together a lot of these recommendations and decisions when we might encounter ECMO emergencies. This is a 7-month-old X28 weeker who presented with increased work of breathing and rhinorrhea. And Ali, can you tell us a little bit more about how you would approach this case as he arrived to the emergency room?
Yeah, thank you. So this baby, upon arrival to the emergency room, was tachypnic with head bobbing, retractions, and use of accessory muscles. He was subsequently started on an 8 liters high-flow nasal cannula and treated for RSV bronchiolitis. By hospital day 2, he had ongoing retractions and increased work of breathing. He was developing significant hypercapnia and was intubated. This was the chest x-ray on the day of intubation. As you can see here, there's progressive hyperinflation and developing opacities. He subsequently developed increasingly high peak pressures with low tidal volumes. He was requiring paralysis, an epidrip, and INO to combat desaturations. His medical management was maxed out using Xopenex, terbutaline, and antibiotic broadening, and the decision was made to place him on VV ECMO for respiratory failure. And this was the last chest x-ray on the day of cannulation, showing this persistent hyperinflation with increasing opacities. As you can see here on this image on the right, he had a right IJ central venous line that had been placed within his first 4 days of hospitalization. Just by a show of hands in here, who would choose to place the VV cannula percutaneously over a wire through the right internal jugular vein CVL site? Okay, that's a good, about a half at least. Who would choose to do this open via cut down? That doesn't quite add up to 100%, but that's okay. Next, I just want to show some images during the cannulation. So the decision was made to place the cannula percutaneously over a wire using the right internal jugular CVL site. I want to stop here again and poll the room. Who in here has the capacity for bedside fluoro for ECMO cannulation at their institution? Good. It's promising. Who here uses serial x-rays and echo for a placement in this situation? Okay. Who only uses or only has the capacity to use x-rays? Okay, good. So just to move on here, a 15 French VV ECMO right atrial double lumen cannula was placed under serial X-ray guidance with echo confirmation after placement, because we do not have the capacity for bedside fluoro at our institution. And the baby was successfully started on VV ECMO. This is the chest X-ray of the final placement of the cannula. And the baby, as I mentioned, was initially started on ECMO without any issues. But within 2 hours post-cannulation, he had developed progressive tachycardia, progressive hypertension, and a narrow pulse pressure. And he subsequently coded. So pediatric surgery was immediately called to the bedside, and the baby was emergently placed onto VA ECMO using the right carotid artery. At the same time we were doing this, our PICU team used POCUS to take a look at the heart and found a significant pericardial effusion. These are the images; they're kind of literally taken on a camera. Those POCUS images, and suggesting tamponade, which had caused the code. So while the baby was being cannulated onto VA ECMO, a pericardiocentesis was immediately done for urgent treatment of these findings. I want to stop here again and just ask the audience if POCUS is being used at your institution currently for ECMO cannula confirmation and troubleshooting. Is that a regular practice at anyone's institution? Great. So I bring this image back up because after the patient was successfully placed on VA ECMO, there was finally a moment to kind of look at all of the data that we had available as to the cause of this pericardial effusion and leading to tamponade. You can see here that the wire that was being used to place the cannula percutaneously is actually circling the cardiac silhouette instead of located within the cardiac chambers. So the conclusion was reached that the wire had likely caused an injury to the pericardium, which had caused the pericardial effusion. We were faced with the decision at this time how to more formally treat this pericardial effusion. And to go through some of the principles that Keith just brought up, we had a multidisciplinary discussion at the bedside, which included cardiologists, the cardiac surgeons, PICU intensivists, and pediatric surgery. The options that were discussed were for pericardial drains, a pericardial window, or for a sternotomy. And again, taking the principle of less is more, or start with less is more if possible, we thought that this would be a small injury that should self-heal. And so temporizing the effusion with pericardial drainage would be the best first option, knowing that we had a plan B and a plan C if that wasn't adequate. These are some images that I bring up during placement of the pericardial drains showing their success at resolving the effusion. So this patient was subsequently managed with the same principles that were previously just mentioned in regards to procedures while on ECMO. So the patient was started on antifibrinolytic, Amicar, was placed on a high-risk anticoagulation bleeding protocol in regards to management of the heparin drip, and the coagulation parameters were optimized.
In conclusion, ECMO can be offered to patients with oncologic diagnoses, and procedures can be performed on ECMO utilizing a institutional protocol. And it's, I think, a good idea to just expect complications, but you've got this. So I think at this point, we're going to start with some questions. And I'll start by asking Patrick a question about what is his approach to bleeding in children with oncologic diagnoses on ECMO.
That's certainly a question that always comes up. You know, as we were talking about before, there's the expectation that kids with oncologic diagnoses are not going to be able to clot like they should and are probably going to have, it's assumed, higher bleeding complications, right? If you cannulate them to ECMO and put them on a heparin drip or bivalve or whatever you typically use. But what I've done in the past is really just plan on starting regular levels of anticoagulation unless they have bleeding at the time of cannulation. And then if there's any sign of trouble, you know, the cannulas start bleeding or develops a bleeding complication elsewhere, that's when I would start going to an institutional bleeding protocol. And those obviously can vary pretty widely, but at all the places I've been, it's pretty much varied from, you know, decreasing the target levels, either if you're following 10A levels or PTT, to having the drip, to turning the drip off completely, especially if you know the bleeding continues. I think it's reasonable to do, no matter what the oncologic diagnosis is. And really, if you look at some of the literature, probably the more important thing to do is to, if you can, to try and tamp down the bleeding, maintain the platelet levels. And the recommendations for maintaining platelet levels range anywhere from about 50,000, but most of the places that I saw recently are recommending maintaining them, if you can, above 100,000. And so maintaining that higher product need and making sure that well, number one, you can provide the platelets that maybe they don't have in the first place should help you deal with a lot of the bleeding complications that you may run into in oncologic patients.
Heather Nolan, Pensacola, Florida. Multiple times you guys have mentioned a multidisciplinary team that you discuss things with. Who makes up this team, and then who makes up this team at 2 o'clock in the morning?
Sort of like, you know, Dr. Ali was mentioning before, you know, preferably you have these discussions as early as possible. So if there's, you know, a kid coming into the PICU for an intensive chemotherapy regimen or some other type of therapy where it's relatively well expected that they may get into pulmonary complications, which for oncology patients is usually the most common reason for ECMO cannulation. That discussion should be had, you know, before even any therapeutics are started, before, you know, the kid gets into trouble. But a lot of times, you know, you can't have that discussion because things happen at 2 o'clock in the morning. And you would hope that, you know, if maybe you haven't had a discussion, then, you know, you at least have the oncologist involved on call, or like, you know, some of the other scenarios that you have, you know, everyone does ECMO or is involved in ECMO to a certain degree, right? And so if you have a kid that you have a cardiac injury, a potential cardiac injury, those CT surgeons should be available and able to help as well. And so I think having a culture at your institution where everyone's involved as early as possible and is willing to be involved as early as possible, even if there's not necessarily anything to do, is probably the best way to go. But those conversations are hard. And really the best thing is to have the conversations early and fall back on sort of institutional guidelines if you can.
The only thing I would add to that is just that guideline is set up before any of these happen, right? That like he's saying, that you have, and maybe you have those thresholds, just as he was saying, is this a treatable cancer or not? Are we at a place we can? And then the immediate part is, okay, how do we get this on? Who's around? And so forth. But yeah, you're right. In the middle of the night, you don't have that. So it's the surgeon, it's the PICU, it's who's around. But hopefully, if you can establish that kind of guideline or protocol in the front of that, when these situations arise, it's less of kind of scrambling to get everybody together. But it eventually, that's what happens, right? There is the train wreck part of things that no matter what happens, if you can avoid that as much as possible, then hopefully you can get everybody going quicker.
So many questions. I became the surgical ECMO director about a month ago, and my name's Tony Escobar from Mary Bridge in Tacoma, Washington. First, I actually 100% agree with the idea of having some sort of protocol guideline, whatnot, in place. What I'm finding is an extraordinary amount of difficulty in getting engagement from the PICU in creating those guidelines. So any recommendations, any kind of insight into your experience in that development would be great. Second, controversy you did not discuss, and if it's off topic, I understand, is what are you guys doing about femoral cannulations? And how are you handling that? And do you have vascular? Like, any insight into that would be terrific, because my PICU seems to think I should be able to pop in a femoral artery and a femoral vein without any worry or concern at the drop of a hat. Thank you.
I can jump in with both questions. I'll start with your first question. So I think, getting a multidisciplinary team on board is kind of one of the baseline things that are necessary to getting things like protocols pushed through. At our institution, and I know some other institutions, there is a core group of pediatric intensivists who are the ECMO intensivists. And so one of them is always on every day for 24 hours a day. Sometimes they take a week at a time. And so it truly helps if your institution has the capacity to even develop a couple of core PICU intensivists who are really, ECMO driven to help start to build some of these protocols, because they can really help kind of like synthesize the agreement within their division on its own. I also think that helps with the 2 a.m. phone call and emergencies that you get, because the case that I presented did happen at 2 a.m. And we were amazingly able to, there happened to be some people who were in-house, there were some people who came in. But I think like knowing that there's a core ECMO team within your unit is very helpful.
And I would just start with the champion and figure out a champion from the PICU and champion from each place, and then grow that team and ask for that.
And then as far as the femoral cannulation question, I think that does vary from institution to institution. And what we do at Brown is we do console vascular surgery, and they put in the distal perfusion catheter into the SFA. And generally, it's better to do that before you actually put your arterial cannula in, so you can still see it. So. Another question.
To close the arteriotomy.
Yes, yeah. So they're involved with the SFA cannulation of for the distal perfusion catheter, and then they help with the repair of the artery when we decannulate.
It's like Julie was mentioning, it's different everywhere. At our institution, the surgeons will percutaneously place the cannulas, including the DPC, and then the vascular surgeons will help with the decannulation. I know at some institutions, IR helps with placement of the DPC, and so it's variable, and I think it's what works with your system.
Abdullah from Omaha. The V cannula that you had, that you converted to VA, what did you do with the 2 cannulas of the VV? Did you hook them together, wire them together, and risk low flow? Or did you connect the arterial one to the arterial cannula and do a VAA? What was the hookup that you did? because there's some debate. We've had this situation, and because the PICU sometimes just says, oh, replace it. And you're going from 13 to 10. Not always a good thing, especially if you've been on it for 2 weeks. It happens. So what did you do with the cannulas?
Yeah, great question. So we left the double lumen VV cannula in place and just placed the arterial cannula. And then we wired together the inflow on the double lumen VV with the arterial cannula.
You did.
Yeah.
So you have two. One stays as venous, and the other one that's A on the VV cannula, you hooked up to the arterial.
Yeah.
Okay. Why? Why not just hook them together?
Yeah, why not just hook the double lumen together? You're
It
saying,
becomes
yeah,
a
and
venous
just use
catheter.
it completely as a drainage. I don't think that's not a wrong solution. What we did is we wanted a little bit of oxygenated blood, feeding the coronaries and going through the heart. And so that's why we decided to hook it up that way.
And then when you put the A, go ahead.
This is
here.
why we're here, the controversies.
I'm just asking. And when you did the VA part, you cut, and you did the open. You put the arterial cannula open.
Yes.
Okay.
Yeah.
And that's a pain to.
Oh, yeah.
The catheter's in the way.
It's a huge pain.
Yeah.
Especially when they're undergoing compressions and they're really edematous and yeah.
Many times when you try to drain both lumen of the VV cannula, one side will clot. Usually the arterial
Right,
side will
is-
clot.
So is the recommendation just to do what you did?
The
to
recommendation is to
VA?
do what Ali did
All the
and to
time.
do a VVA. Yes.
Andrew Zigman from Portland, Oregon. Sorry, do you want to continue perseverating on the cannula juggling, or just can we go back just to review the 3-day-old with the respiratory failure case that you were consulted for a lung biopsy?
I think it was a 3-week-old because
Oh, 3-week-old.
Yeah.
Awesome.
We
Even
may have
better.
left it as 3-day as a
It's a
typo, but it was.
3-week.
For this discussion, let's call it a 3-day.
Yeah.
So it's a little learning to share. We were able to get out of this situation by sending a neonatal respiratory failure panel, genetic panel. And whereas previously, 3 weeks, let's call it 3 days for the sake. So there's a neonatal respiratory failure panel, genetic panel that can be sent now, which might get you out of the request for a pulmonary biopsy, for alveolar capillary dysplasia and that type of thing through Invitae. I have no financial relationship
Yeah.
to them.
Well, how soon does that come back? And is it like a serum plasma test? Because many times when we're blood priming the circuit, that can be a problem for the genetic test that we try to send.
Absolutely. They had some blood from prior to cannulation, and we got the result back in about 3 or 4 days.
It's taken a little longer at my institution, so I'm going to have to find out how you got that
Yeah,
back
it
so
was-
quickly. Yeah.
A great improvement over a lung biopsy.
Yeah. Yeah.
Absolutely.
Any other questions?
Hi, I'm Melissa Danko from Emory. This is a loaded question too. We've talked about operating on ECMO, but haven't really addressed the anticoagulation. I know every program does it differently, but do you guys have recommendations? How do you do it? How did you come up with your institutional protocol?
So, how many people use bival? So we exclusively use bival. I think yesterday there was some interesting discussion on that, but I missed a little bit. But the reality is there. If you look at the clotting cascade and you look at the kind of the dynamics between heparin and bival, heparin probably does have a little bit more higher tendency to bleed comparatively to bival. And so but we have not in our kind of institution at Hopkins. We have seen we have a very kind of straightforward, strict protocol as to how we start the bival after we cannulate, and then kind of how we reduce that in half when we go on to operate and kind of watch. And essentially, we kind of clinically will watch as we go. But we have ourselves therapeutic, but we're kind of just getting to that therapeutic range, to be honest with you, because we operate within 24 hours once we're on. But we will usually about half that, and kind of from there, we'll just kind of get a sense or a gestalt of what we're seeing. As far as is everything bleeding? Is it just the small things? What are we seeing? And then we will adjust further with that. Constant communication with our anesthesia colleagues. What are our platelets? What's our blood level? What's everything? We're constantly checking all those. We're getting tags constantly as well.
Ian Mitchell with UT San Antonio. This is a very loaded, and I'm happy to have a small discussion group afterwards, ECPR. And my question is probably more of a poll would be, we have a real trouble trying to determine the difference between doing ECMO, getting someone on ECMO really fast, and we have now been pumping on the chest for 45 minutes and we want ECMO. And realizing that's a loaded question, I'd actually just love to hear the panel's experience at each of your institutions, because for us, there's a lot of differences between our people in-house, our people at home, who is in-house, all of those things. And I'd just like to hear your...
I think the resource, right, it comes down to what is the resource control. And so all of us can potentially do it in the middle of the day. But is that fair? Is that the right thing to do? And so I think we don't have a vast experience of it. We have 1 or 2 kids that we've done during the day that just happened to come in that moment, but we do not have a program, so to speak. I think there are other ways we have a pretty big CDH program, and some programs will do their exits, but we actually will cannulate our severe kids within about 15 minutes of life. So that's a different ball of wax. But I think you have to, I think there are communities that, from an adult perspective, that have taken this on, and they have on-call physicians that will drive with the ambulance to cannulate. That's a resource that in the peds world we just don't have. So ethically, that's the question. Like, what is the resource? How do you do it? Do you do it during the daytime when you can't really do it at night?
I can speak to the process a little bit from our institution. So we are going through a whole kind of multidisciplinary systematic effort to create a systematic ECPR plan. And so this has been going on over the last about 6 to 9 months. And basically, it has members from the cardiac ICU, the NICU, the PICU, the ER, because patients come in through the ER, the pediatric surgeons, the perfusionists, et cetera. And basically what we're doing is I've found in this process the most time that we're spending on creating that system is figuring out why kids in respiratory failure really wind up needing ECPR, because ultimately you want to be putting them on ECMO before it becomes an emergency. And so figuring out, like we really do a root cause analysis of these ECPR cases to figure out what was missed in the 5 hours beforehand that could have made this not an emergency. I think the other thing we're doing is we're doing things like creating a pop-up on we use Epic as our EMR, but creating a pop-up that as soon as someone in the PICU starts undergoing a code, there's a pop-up that says, did you call the ECPR team? So that you get people thinking of starting the ECPR process earlier, not 45 minutes into the code and the chest compressions and everything. So we've been doing things like that to automate the process. I think, the next piece, which we haven't done yet, is honestly simulating it so that you can get these kids on ECMO as fast as possible in terms of the procedure itself, in the midst of chest compressions, et cetera. So that in itself is a whole other part of the process that we still have to do. But I think creating the system that takes it out of the subjective mindset of all the other thoughts that are going on during a code to actually get the process in place is helpful.
So I built a ECPR program, voluntold, not on purpose at our program in Cincinnati. And one thing we do, I think I agree with a lot of your perspectives in that, and we don't take in-house call, and we don't have cardiac fellows, and every ECPR is after 2 in the morning. At the second dose of epi, which is approximately 5 minutes into every code, the decision has to be made then, is this patient an ECMO candidate? And an ECMO, we send off our ECPR code just like our trauma page, so it just goes off to everyone, and so that's how we do it. So there's no 45 minutes into a code where ECPR is allowed to be called. It's at approximately somewhere between 4 and 6 minutes, about 5 minutes. It's yes or no, and then it gets activated. I live about 20 minutes from the hospital. We get on, there's plenty of data that shows if you do good compressions for about 60 minutes and you're on, you're pretty good. You're watching your pHs of those patients. And our data is okay. It's not 100%, it's not zero, but that's how we sort of built it to sort of mitigate some of those things you're saying. And we do lots and lots of sim.
Just going to add the TCH crazy perspective to all this because it's nuts. You know, Jason mentioned high quality CPR. It's really hard to do that when you're saturating in the 50s, right? Like in respiratory arrests, you're not really getting good blood flow to the brain. So I think Dave Rothstein from Seattle just had a whole multidisciplinary or multi-center retrospective review on ECMO CPR. You know, the outcomes for ECMO CPR for respiratory arrest really do suck. So it's very institutional. So for us, we are in-house, our cardiac folks are in-house. We will actually only do ECMO CPR for known patients with cardiac problems or highly suspected, because in that case, you are delivering high quality CPR with good SAS to the brain and things along those lines. And our goal is to get them on between 15 and 30 minutes from the activation. And so we have a in-house CICU doctor who's the gold standard. They hit the button, they activate, and it goes. But I think it all speaks to what are the resources in your institution, because everybody's going to be different and have a little different take on that. 45 minutes of CPR, we wouldn't cannulate. Like that wouldn't be an ECMO CPR candidate in our universe. But I wonder what the Columbia perspective is.
I don't know, he trained me.
Hi, it's Bill Middlesworth from Columbia. I just want to make a couple comments. One of them is we talked about how we adjust heparin on ECMO, and it's really different in an infant versus an adult-sized person where you can just stop the anticoagulation, right? So an adult-sized person can go for days sometimes without any anticoagulation. So just to make that distinction for the audience, that a newborn, though, can't, and so you have to do the measures that were talked about, and I think the important ones are maintaining the platelet count over 100. We tighten our anticoagulation. We don't try to wean the flow. We might even increase the flow a little bit above what the baby needs just to prevent stasis. And then the ECPR thing is such a painful, loaded question. I think that we've tried to get our ICU, ICU rounds now have a lot of checklists in them about, can we take the central line out? Can we take the Foley out? And if you can get the intensivist to have on there, is this patient an ECMO candidate or not, it at least eliminates some of the kids who've been thought through and have decided that they're at the end of life and we shouldn't consider ECPR. And I think that's helpful for the team. And then one last thing, and then I'll shut up, is I think that we have to really worry about what happens to the mindset of the intensivist when we have an ECPR program with an automatic activation like Jason talked about, because you have a real vulnerability to not treating the immediate causes of cardiac arrest that don't require ECMO. So you call ECMO when someone has a tension pneumothorax, or you call ECMO when someone is in hemorrhagic shock, or, I think that there's a real danger of, in the mind of the intensivist, everything defaults to ECMO as the rescue when there are treatable causes of cardiac arrest that don't require ECMO. And I think that that's a real problem that we're seeing at our institution, and just to, a little caution about that.
Thank you very much. I think we're all out of time. Yeah.
Thank you, everyone.